Thanks for joining me today to talk about hearing aids and hearing assistive technologies. To be honest, this is one of my favorite topics because this is how we can really make an impact on our patients. Because for them to develop speech and language as children and to have effective communication as children and adults, they have to be able to hear the speech in their environment as well as other environmental sounds for safety even. So I look forward to talking with you more about this and also helping you to complete some activities that I think will enhance your knowledge in this area. This lecture goes along with Chapter 2 in your book, Introduction to Audiologic Rehabilitation. First, I want to review the hearing aid components, or maybe this is new to you, maybe it's not review. But regardless of manufacturer, and there are several manufacturers that we'll learn more about in our activities, the components are really the same. So number one, we've got our microphone. On this behind the ear hearing aid that you can see in the figure on the right, the microphone's at the very top where this little ear hook piece attaches. And so the microphone's job is to take that acoustic information and convert it to electrical information or electrical energy. And the microphone can be omnidirectional, which means that it's sensitive to sound from all directions, or directional so that it focuses in on a specific direction. Most often that would be directly in front of the person because you usually face the person that you're speaking with. And if you look at number one here on the right, you see that it's pointing to two ports there, two microphones. So this is a directional microphone. And you all have heard directional microphones for years because they're commonly used by commentators that are on the field at football games when they interview players. So otherwise, if it was omnidirectional, it would pick up all that crowd noise. The second step in the signal processing line for hearing aids is the amplifier. So within that amplifier, you have a digital processor, which takes that analog electrical signal and converts it to a digital code, so an A to D converter. And then that digital processor manipulates the sound to meet a person's hearing needs, so based on their hearing thresholds. Number three, it goes to a receiver where it converts the digital code back into an electrical signal, so a digital to analog converter, because we need the sound to come out in a recognizable format to the listener. And then, of course, we've got to have power. So we have batteries. And as described in your book, there are several different hearing aid batteries available to consumers. And the battery type is dependent on the size of the hearing aid. For example, smaller batteries, such as the size 10, which comes in yellow packaging, are for smaller hearing aids, whereas some of the biggest behind the ear hearing aids are run by a kind of a disc-shaped 675 battery that has blue on its packaging. So hearing aid styles. There are a lot of styles as you can see in this figure, and there's really a fit for every ear. We have a traditional behind the ear hearing aid here on the far left, and you can see the little ear hook attached to it, and we would attach an ear mold to that type of hearing aid. And then we've got receiver in the ear type hearing aids in the middle, where you have a special slim tube and dome on the ear that fits in their ear. And then we've got custom devices, the in-the-ear products on the far right. And so we actually have to take an impression of the ear for those on the right because it is custom made for that person's ear. It honestly is a harder fit, and those types of products break down more than anything that goes behind the ear. And the reason for that is the moisture that is normal in an ear in the earwax. And so when you've got a whole hearing aid in the ear, it's just subject to more moisture and wax and wear and tear. So let's look more closely at each style. So let's start out with the behind the ear hearing aid. So you can see those in the top pictures on the right. They are encased in plastic, and as I mentioned on the previous slide, are worn with an ear mold. It's really fun when you work with kids because you get to order cool colored ear molds like this swirl pink and white one. on the right. And so behind the ear hearing aids are the gold standard for children for many reasons, but most importantly, safety. So we don't want a big plastic piece in their ear. Those ear molds are pretty soft and kind of flexible. So if the child fell, they would not get hurt because of that flexible ear mold. Also, the ear mold piece only costs about $30, whereas the hearing aid can cost up to, $2,500 or $3,000. And kids' ears grow. So we want to be able to order a new ear mold as they grow, which could even occur in 1 month in some babies. You know how fast babies grow. So those are commonly used for people with pretty severe to profound hearing losses as well as children. The second type is the receiver in the canal. It's still fit behind the ear, except the receiver portion goes down in the ear canal. So if you look at the picture in the middle on the right, you can see the receiver portion is the little black dome that goes in the ear. It's actually got a great appearance. If you look at the picture on the left, you barely see it. It blends in with this woman's hair, and the receiver is sitting in her ear canal. And part of the reason why it's not very visible is that really slim tube that can be used with this type of instrument. So people who use this really like the sound quality. It's really good sound quality. Most of them have good directional microphones, and the appearance is not that great. And finally, we've got the custom type hearing instruments on the bottom, the in the ear and the completely in the canal. There's actually 4 different types here in the picture shown. So in the ear is the largest. You see that in the far right picture. So it takes up the whole concha of the ear. I actually don't think that's a very pretty option. I would much rather like to have the middle one, the receiver and the canal, personally, and I would prefer to fit them on patients as well. You also can have an in the canal or half shell, that's the middle 2 pictures. So the in the canal just fits a little bit deeper than the half shell. The half shell is truly half of an ITE. So you can see it doesn't take up the whole concha. The very top of the concha is open versus an ITE, it's not open. And completely in the canal, you can see it's completely in the canal. So you do need to have a little pull string, and it's hard to see it in the picture, but it's a little clear pull string where the patient, it sits kind of in their canal so that they can get it in and out. So they use the string. This is not a great option for elderly individuals with dexterity issues. Again, I would much rather fit receiver in the canal on the majority of patients and a traditional BTE or behind the ear hearing aid on children and patients who have severe to profound hearing losses. So who's a candidate for a hearing aid, and how do we select the type of hearing aid? Well, I just mentioned that we might need BTEs for people with severe to profound hearing loss. So the number one factor that we consider when determining if you need a hearing aid is the degree of hearing loss. And any degree of hearing loss makes you a hearing aid candidate. So we even fit those with mild hearing losses ranging from about 25 dB HL to 40 dBHL. So I start fitting hearing aids even with a mild hearing loss, which can severely impact communication. And certainly we fit people with any greater degree of hearing loss. So number 2, I might look at their degree of communication problems. Maybe I have a patient with a mild loss and I really think they could benefit from a hearing aid, but they just aren't really communicating much in their daily life. Maybe they're just not very social, or maybe they have really significant financial issues. I'm going to have to take a hard look at whether or not this person is having major communication problems before I recommend a hearing aid. Number 3, motivation is a big issue. If the patient tells you outright, I'm not wearing a hearing aid, well, maybe they're not a good candidate, or at least at that point in time in their life. Maybe you need to see them for some follow-up appointments and do kind of some personal adjustment counseling to help them accept the hearing loss before they're willing to move forward. Number 4, an important consideration is any loss that cannot be medically corrected, really that person is a candidate for a hearing aid. And finally, when I'm fitting the hearing aid itself, I can use prescriptive strategies. One example of a prescriptive strategy, and these are discussed in your book, is the desired sensation level strategy. And really, what these strategies do is tell you how much amplification to give someone, and we call that amplification gain. So, for example, if I had a patient who had a hearing loss at 1000 hertz of about 40 dBHL, I want to get them close to the normal hearing range, so I need to improve their hearing by 20 dB or give them 20 dB of gain to kind of get them close to the normal hearing level. Prescriptive strategies aren't really that simple. It's not simple math. It takes into account a lot of other issues about hearing loss as well, which we've even talked about, the distortion issues. So, but that gives you an example of what a prescriptive strategy might do. So those strategies determine the gain you need at each frequency or pitch. And so that's something you really learn a lot about in a Doctor of Audiology program, what strategies to use to fit. When we're fitting a hearing aid, we also want to use verification and validation because we've got these great hearing aid test boxes and other objective measures that we can use to do a good job at fitting a hearing aid and provide high quality standard of care for each patient. So each patient should receive electroacoustic measures and a hearing aid test box. And so you actually don't even need the patient to be there. That box itself is on the right of the screen here, and you can measure hearing aids in this box without the patient. So you can get your hearing aid set with your prescriptive strategy by just entering their hearing thresholds in this hearing aid test box, and then by setting the hearing aid based on the recommended gain. And so it's actually pretty easy. But when the patient arrives, you need to do real ear verification, which you see this woman doing with her audiologist on the right in this picture. So basically, you put a little tiny probe microphone in the ear canal, not really deep. You don't want to poke their eardrum or anything like that. So you put it right down in their ear canal, and then you can put the hearing aids on, and she doesn't have her aids on yet in this picture. And then you put sound through the microphone, through the speaker of the hearing aid test box. And so you're making sure in that patient's ear that you're meeting the targets or the levels that were recommended by the prescriptive strategy, such as desired sensation level. So you want the output to be right in the patient's ear. So the reason why I need to do it on the actual patient's ear is because, as you know, ears are different shapes and sizes. And so the resonance of the ear canal is different in every individual pretty much. It's variable. So in infants, even some infants have really tiny ears and some have bigger ears. And then, of course, if you think about a little bitty older lady, her ear canal is probably a lot smaller than a guy who is 6'7", a great big man. So we really have to put it in their ear to make sure the output is correct. What would happen if you didn't do this is if you had a tiny ear canal, a smaller volume in a space causes higher output, so we could over amplify and actually damage someone's ear. So we really need this objective measure to fit hearing aids. The third thing we can do while we're fitting is measure speech perception testing. And this is routinely done in an audiologic evaluation. So we want to know how well the person does with and without their hearing aid. And this can be done in a quiet sound booth. And we can ask them to repeat words like, say the word get, say the word dog. Or we can do it in background noise. And sometimes we use multi-talker babble, which just sounds like you're at a party. And we ask them to repeat with and without their hearing aids. And so we can actually measure the benefit using these speech perception measures. And the final way, and a very important way, is the use of self-report measures, which are just patient questionnaires. So what I want to do is ask them, hey, how are you hearing now that you have your hearing aids? We also want to know other things like how much are you using your hearing aid? How much benefit do you think you're getting? So you can repeat these questionnaires before and after a hearing aid fitting, or you can just do it one time after a hearing aid fitting based on how the questionnaire is worded. So there are a ton of questionnaires. And if you'll take a look in your book, you can see a summary, but I want to talk about one questionnaire that I think is pretty great, and that is the International Outcome Inventory. It's called the International Outcome Inventory because it actually comes in, I don't know, 20 some odd languages. I can't remember how many, but it's just a quick 7-item questionnaire, and it provides information about the amount of use, so how much are you using it, perceived benefit, residual activity limitations, residual participation restrictions, and I hope you remember those last two from the World Health Organization model. So those are important questions. Other things that they find out about are the impact on others, overall satisfaction, and the quality of life. So it actually has many languages available. So if you are working with a patient who has English as a second language or speaks another language only, you would have the opportunity to assess benefit in individuals who can read this questionnaire. Another important consideration, obviously, is pediatric fittings. So, when fitting children, it's not just the audiologist involved. We actually need to do this as a team. And so, the family, of course, is critically important to be involved in this process because when they leave the audiology clinic, who is monitoring the hearing aids? Of course, it's the parent. We also want to include the speech language pathologist because I would say 95% of kids with hearing loss are seeing speech pathologists. And so we want that speech pathologist to be able to troubleshoot the hearing aid, listen to it and make sure it's working properly, and help us, as a team to monitor this child's improvement in speech and language changes post hearing aid fitting. So then first important thing for pediatric fittings is you want to do it quickly. We want children with hearing loss to be screened for hearing loss at birth, and we want that hearing aid on as soon as possible. So we have fit children with hearing aids even at 2 weeks old or 3 weeks old because they must have that sound. They must have audibility to be able to develop speech and language, which, as you know from your courses, starts to develop very early. And so we have these early milestones and we want to help these kids meet them on time if possible. So early identification is key. We want those newborn hearing screenings. And those screenings are done through auditory brain stem response, or ABR, where we place inserts or headphones on the baby and look at the brain's response to sound. So it's a very objective measure. And we can measure the brain's response by placing little sticky electrodes on their head. So it's a pretty easy task done in many hospitals across the United States and worldwide. We can also use otoacoustic emissions, which measures a response from the cochlea. We actually put in a sound to the cochlea, and then the cochlea responds back with a little tiny sound that we're able to measure with a very sensitive microphone that we just place in the ear. It's just a little probe microphone that sits in the ear. So, two really good ways to measure hearing in infants. And once we find out that they have a permanent hearing loss, we need to get those hearing aids fit. So, as I mentioned earlier, we want to fit a behind the ear hearing aid with an ear mold. We also want to use a retention clip, like is shown on this little boy in the picture on the right. So, you see his behind the ear hearing aid behind his ear, and you can see his clear ear mold in his ear, which is attached with tubing to the behind the ear hearing aid, but you also see a cute little retention clip. So before we attached the ear mold to the hearing aid, we slipped on this little cord or retention strap, and then we clip that to the back of his shirt. So it's a cute little robot. And if his hearing aid falls out of his ear on the playground, well, guess what? It's just hanging on the little retention clip and cord. So that's important. We do not want to lose these super expensive hearing aids. Also, as I mentioned earlier, we may need to really monitor these kids closely so that we can order a new ear mold piece when we need to. If we don't get a new ear mold, first of all, we're losing sound out of the ear. And when you lose sound out of the ear, it makes that really horrible squealing sound called feedback. So when sound comes out of the aid and goes back into the microphone, that's called a feedback loop because it's looping back up into the hearing aid. So we want those ear molds fit in there very well, and they may need to be replaced every 1 to 6 months in young kids. Also, in young kids, we want to use the desired sensation level prescriptive strategy to determine how much gain they need in their hearing aid because it has the most evidence to support. So that's why we use it, because we want to do evidence-based practice, and DSL has the most evidence to support its use in children. We also want to do real ear measurements in children because, as I mentioned, they have tiny ear canals, and we don't want to provide too much amplification where it either hurts the child so they refuse to wear their hearing aid, or it damages their remaining hearing, neither of which we want to do. And then finally, we want to provide tamper proofing on the hearing aid so that the child cannot open the battery door. So we have a little way where we use a tool to open the door instead of them just being able to open it themselves and ingest the toxic battery. And parents really require a thorough orientation. Honestly, all patients require orientation, but parents are really overwhelmed by the hearing loss to begin with. And so we need to make sure that they understand how to insert the hearing aid, so take it on and off. How long should the child wear the hearing aid throughout the day, which is typically all waking hours? How do you change the battery? What do I do if I can't get him to wear it? So all these things, parents need to know these answers before they're asked to go home and take care of these hearing aids on their own. Some other special fittings there's more information in your book about this, but I want to mention them. The first is the contralateral routing of the signal. And we would use this option when a person has a unilateral hearing loss or a hearing loss only in one ear. So if you look at this figure on the right, you can order different styles of hearing aids, but the point is when you have a dead ear that a hearing aid is not going to help, you miss information on that side of your head. So if your friend's talking to you and your right ear, but your right ear is dead, it can really cause a problem hearing when speech is presented to that side. So goal of this aid is you wear a transmitter, which looks just like a hearing aid on one side, but it's actually just a microphone that will send the wireless signal over to the other side where you have hearing. So it's cross hearing. You can also order a bi-cross where the side with the microphone also is a hearing aid itself, but then we'll still send it to the other side as well. So that's when you need a little amplification in both ears, but one side is dead. I'm sorry. So over here is a microphone, on the other side is a hearing aid. So that's a bi-cross. Bone conduction, which you can see in the picture below, is used for people that don't have an ear canal. So you may have heard of patients with Treacher-Collins syndrome. They don't have an ear canal, so we can't get normal sound through. So they have to wear a headband that vibrates the skull so that sound can get into the cochlea, which is normal. So the inner ear is normal. We just can't get sound through because they have no ear canal, and sometimes they don't even have an ear or a pinna. You can wear that on a headband, which you can see on the left, or a soft band, which you can see on the right in this little boy's picture. And we usually do soft band trials for people who are considering a bone anchored implant, which is on the next slide. So here we can see a bone anchored device. So you can, the FDA or the Food and Drug Administration has approved bone anchor devices for children beginning at age 5 because their skull is still growing. And this is where you receive a small titanium implant and it goes into your mastoid bone, which is right behind your ear. So just tap that for me right now. It's a very hard bone. So it's seated in the bone. So after you get this little abutment, you let it grow or let bone grow over it. It's very simple, similar to dental implants if you know somebody who's received one. So once that abutment has kind of fused with the bone, then you just hang a little hearing aid on it, or it's called a sound processor. So it's actually pretty cool and provides sound directly to that inner ear or cochlea, bypassing the outer and middle ear. So people who get those usually don't have an ear canal or sometimes have chronic ear infections. You can also get one with a unilateral hearing loss. So there are actually several patients who may benefit from that. Another special fitting is a middle ear implant. Again, requires surgical intervention. So these three on this slide require an otolaryngologist who specializes in that particular type of implant or device. So they do the surgical part and audiologists do the programming part of the external device. So here on the right, you can see a middle ear implant. It's the gold inside the ear. And then on the outside, they wear a sound processor that's very similar to the one in the picture above. And so why would you get this? Well, if your middle ear bones are not working, or maybe you have a disease called otosclerosis and you're getting bony growth on your middle ear bones, you can replace one of the bones with this implant so that it really vibrates, mechanically vibrates the middle ear bones, making better transmission of sound to the inner ear. The final one on this slide is cochlear implants. Another topic near and dear to my heart. It is exactly what it sounds like. We are going to put an implant threaded through the cochlea, and we will talk more about that in the next chapter and lecture. So I'll come back to that one. Finally, I want to talk a little bit about hearing assistive technology or hearing assistance technology. Some people will call it HATS for short. And that's hearing assistance technology. And we can have hardwired devices where the microphone is on the little box and we can talk into the box and our patients can hear us with headphones. That is one of the least expensive options and kind of cumbersome because you are literally hardwired to the person you're talking to. But I have definitely used these. So in skilled nursing facilities, those are a really good option. Or if you have a patient that comes in and they're so hard of hearing that you can't even have a basic conversation, you could easily pull one of these out of the drawer and talk to a patient. We also have wireless frequency modulation or digital modulation systems. So it's the same concept as the one in the first picture up there on the right. The only difference is it's wireless. And so what we do is on the picture on the right, you can see the primary talker wears a microphone, which sends a frequency modulated or digital signal to a receiver in the immediate area. Usually within about 30 feet, and the receiver that this person is wearing around their neck, that's called a neck loop, sends the information up to the user's hearing aid through electromagnetic or some other type of transmission. Another option is to get a small receiver that can plug into the bottom of the hearing aid so that they don't have to wear that neck loop portion. So these are awesome. And on average, for example, if you've got a person with a pretty substantial hearing loss, without it, they may get about 30 or to 40% of words correct in a noisy environment, but with it, they may improve to up to 80 to 100% because you're taking that signal and putting it directly in their ear. Some other hearing assistance technologies are infrared systems. This is shown on the right. For example, the Dallas Summer Musical Theater has an infrared system, so listeners can pick up a receiver and the transmitter sends out a light signal that is then connected to the receiver that accepts that light signal. So it's really interesting the way it works because it takes an acoustic signal and instead of converting it, and like a hearing aid, it converts it to light and then sends it out, and then the receiver converts it back to sound. And then on the left picture, you can see an audio loop system. So this is a literal loop that is placed around the room, and that loop sends out electromagnetic information, which can be picked up by a hearing aid that is set to telecoil. So inside the hearing aid, if you look at number 4 on this picture, that little coil, that's called a telecoil, which is in many hearing aids that are a little bit bigger. And you can order one with a telecoil. So if the person has a telecoil and they're in a looped room, all they have to do is turn on their telecoil and automatically they can hear the signal that's sent through that loop system. Finally, we have hearing assistance technology that will help with telephones. So this is a CapTel device that types it out for them, but we can also have phones that are amplified telephones, and certainly there are ways to connect your phone directly to your hearing aid, whether it be hardwired or wireless. We also have TV devices, and this is probably the most famous one, TV ears over here on the right. And basically, you just set up a transmitter from your TV, and it comes to this receiver or the TV ears, and they just put it directly in their ear. And we can also have some alerting devices or devices that connect in many ways. So this is one company, so I could give you one example. This is Bellman, and they have specific devices for the door over here on the top left, devices for the telephone, so it'll flash when there are incoming calls, specific smoke alarms that are either louder or flash, a baby cry transmitter, so you can hear when your baby's crying by this flashing light. Over on the right, we have several receiver options, so the user could wear a pager. When the doorbell rings, they'll get a page or it'll buzz, or when the telephone rings, maybe the buzz will have a different pattern. Down one, you see the alarm clock receiver. So it actually shakes your pillow, or you can put it under your mattress and it'll shake your bed. This is a flash receiver, down one more, so it'll flash instead of the bed shaker or in addition to the bed shaker. And then here's a portable receiver. So there are just endless options of assistive technologies for people with hearing loss. So what we really need to do is take a look at their needs through our case history and questionnaires. And certainly we want to address hearing aids, but we also need to address assistive devices because we're looking at them as a whole person in every environment in which they need to communicate or hear environmental signals. So I want to thank you for joining me today and listening to this chapter, and I look forward to talking with you soon.